What's up, everybody? Welcome to this week's episode of the Well Man's Podcast. My name is Brian Brozy. I'm joined by my friend and co-host Keoni Tita. Keoni, how are you today?
Doing wonderful. I'm happy to talk about this one because this one really made me think about eye health more so than the other ones that we did. And I'll get to why, but
Okay.
it's really interesting because we did macular degeneration. We talked about cataracts. This is like third part in that series. Now we're going to talk about glaucoma. All three of those, which I really didn't know. I mean, I kind of knew, but not to the extent that how important it is to preserve your eye health and how natural therapeutics can really help you do that.
Yeah.
In all three of those conditions, most people think about macular degeneration being the one that is most amenable to natural interventions and prevention, but all three of them can be vastly prevented through just taking care of your eyes with lifestyle, but definitely with natural therapeutics. And we'll get into some of that with glaucoma. But the interesting thing about glaucoma is it's one of the main causes of blindness worldwide. And unfortunately, it tends to be an irreversible blindness. And the really bad thing about it, it's kind of like blood pressure or rise in blood sugar as you get older. It's really insidious for certain types of glaucoma of how it comes on. So you just don't know that it's happening until you actually lose some eyesight. And if you let it keep going on, it can certainly cause blindness.
Oh man. So is there when you go to the optometrist and you have your check-in, is there any sort of check-in that they do on, is glaucoma, like we said, it's pretty insidious. Any
So you're bringing up
development?
a really good point that made me go, damn, I haven't even thought about that. I was like going to my primary care physician, and if I had an eye issue, I would, maybe mention it to them. I never have. But really, people really should, I would say, between the ages of 30 and 40, at least if you have good eyes where you've never been to an optometrist, I never have, right?
Okay.
Is you should really go there and get a baseline because you don't know what's going on with your eyes. And if it's, glaucoma related or some of the other things, other eye disorders, I mean, at least you establish a baseline and they can see what may or may not be going on. So
Yeah, that's a very good point.
yeah, if you establish it, and so with these podcasts that we've done, I mean, I already have my appointment set up with my optometrist. No referral needed by my primary care physician. I'm going there and just get a baseline eye exam. I have some issues that I notice. Maybe it's age related. I don't know. I mean, I'm over the hill, over 50 now, and so I noticed like different things where my eyesight is just a little weird, like I have to strain sometimes or things. So, but I think it's good to get a baseline even before the age of 50. I think between 30 and 40, and then based on what the optometrist says, keep going. Because if you catch like if you catch glaucoma or the beginnings of it, you can completely preserve your eyesight. It's completely preventable. And a lot of people don't. And the problem is it's insidious. It's like blood pressure, right? Your blood pressure, you don't feel that getting high. I mean, unless it acutely gets high. But over time, that blood pressure rising like destroys the eyes, can destroy your kidneys, just, devastates the body. So glaucoma is the same thing with eyesight. And the reason why it's can cause blindness is it actually increases pressure within the eye, right? So you get pressure that can't fluid builds up in the eye and it creates pressure that can't drain.
Okay.
All right. So let's go over that real quick. And I think to go over that, let's just talk about, I'll try to explain like the anatomy of the eye. I know this is going to get confusing for people, but I think it's helpful just so people will know.
But that's kind of the skinny of what's going on, Keoni. We get
Yeah,
this
right.
buildup of pressure.
Right, you get this buildup of pressure within the eye. It's fluid pressure, and then what it does is it in the back of the eye, you have your retina and your optic nerve back there, and what it does is it just that pressure creates free radical damage, causes cupping in the optic nerve that allows you to have eyesight. It thins the layer of the retina, and slowly but surely you start losing your vision. And a lot of times your vision starts losing from the periphery, and you don't really notice peripheral vision loss until it gets really to some great extent for the most part.
So this is
But
a
yeah, so
lot like high blood pressure, really.
it is, but it's not related to high blood pressure.
Right.
It's not. So let me say this. It's not related in this way. So if you have high blood pressure, it does not necessarily mean that you're also going to have this intraocular pressure. Okay. However, there is some correlation with high blood pressure and glaucoma. All right. But it doesn't mean that one causes the other. But there does seem to, people with higher blood pressure do seem to be more prone to glaucoma. So that's a risk factor.
Yeah. And it just, in a similar pathological way, kind of works very similar. Like we think of the degeneration of the arteries from all that extra pressure.
Yeah, you can think about it. I think that's a good, simple way to think about it.
Yeah, I'm giving you the dumb version. I'm giving you the kindergarten version.
Well, no, it's actually a really good way to think about it. But so now let me get into some detail about the eye. The eye is a fascinating structure. I mean, it just blows me away how, millions of years of evolution came up with the eye. And actually, this is getting off the subject, but millions of years of evolution came up with numerous versions of the eye and numerous species, which is just fascinating to me. But anyway, so when you look at the eye, when you look at yourself in the mirror, what you tend to see is the white part of the eye, right? That's the sclera. And then if you look in the center, you see the black dot in there. That's your pupil or your lens. And around that pupil, you see the iris, and that iris is usually colored. It's the colored part around that pupil or lens. But and then over the iris and over the pupil there, going from exterior to interior, you have the cornea, and then right behind the cornea you have something called the anterior chamber. All right, so that's the space between the cornea and the iris and the lens.
Okay.
All right. Okay. And then as you go through that anterior chamber of the eye, you hit the iris, and then just kind of like right under the iris, you hit the lens, and then right below the iris and near the lens, you have the posterior chamber. Okay. And
that's kind of a description working from very anterior surface of the eyeball, the whites of the eyeball,
and going into the eye, into the eye, right? And then once you get into the posterior chamber and beyond the lens, you go all the way back to the back of the eyeball, right? You have the retina, and you have the place where the optic nerve comes out, and the optic disc and stuff like that. But for our purposes, I just want to give you a little bit of the anatomy of the anterior of the eye, because a lot of people don't understand, like, what's the difference between, open angle glaucoma and closed angle glaucoma. Okay.
I do not either.
All right. So let me just explain how this works, because if you understand the anatomy of the eye and you understand what's going on, then you can get an idea of why certain meds work for the eye and why certain natural therapeutics will work for the eye. Okay. All right. So we're kind of attached to the iris is something called the ciliary body, or the ciliary epithelium. And right there in that ciliary epithelium, you get production of what's called aqueous humor. It's the liquid that kind of fills the posterior chamber and anterior chamber. It's the liquid that fills its space between the cornea and the iris, so to speak. All right. And that liquid is produced from the ciliary epithelium, which kind of lies right below the iris. And that fluid will go from the iris up into the anterior chamber, and then it will go through something called the trabecular meshwork, which just helps divert the fluid into something called Schlem's canal, and then puts it into the blood. So think about it as just a continuous production of fluid that gets recycled and goes back into the blood. Well, if they're anywhere along the way there, right, if there's any stoppage where that fluid gets dammed up and can't go in there, now you have a buildup of intraocular pressure, and that fluid has nowhere to go. Mm-hmm. All right. And so if you're thinking about, go ahead.
Are you going to feel this in any way?
You can, but for most glaucoma, you don't really feel it. No, it's very insidious. Some of it is. Glaucoma is really is defined in two types of glaucoma. So one is open angle glaucoma, the other one is closed angle glaucoma. The closed angle glaucoma usually comes on quickly, is very painful. Yes, you feel it, and it's a emergency situation because it can cause blindness right away.
Okay.
So what is this angle we're talking about when we say primary and the open angle glaucoma and the closed angle glaucoma? Right. It's the angle, kind of think about it, the angle at the corner of the cornea and the iris. The cornea like comes down onto the iris and it forms an angle at the iris. So think about like almost like the cornea causing like coming up out of the sclera and the iris, and it creates like an angle there. Okay. Mm-hmm. So if you're just thinking about the anatomy, so you go through the cornea to the anterior chamber, that's a fluid filled chamber, and then to the iris. Well, you can think about that as like a triangular area that's open that has that aqueous humor in it. Okay. All right. So if it's open and you get glaucoma and that fluid's building up, well, something is going on where it can't flow out of the tubercular meshwork or Schlemm's canal, right? So it's like either dammed up or something. There may be genetic factors or just debris that's causing that as an issue.
And that's open.
It's open, right? Okay. Like so we're thinking, well, maybe it just the fluid can't flow out easily. And then closed angle glaucoma is where you can think about the cornea and the iris almost laying on each other, where there's no space there, where the anterior chamber has shrunken. Right. Okay. Where that edge shrunk. And that is more of an emergency situation. And that is more of a significant structural problem, like where the iris kind of becomes like glued up to the cornea or vice versa, the cornea to the iris. So anyway, I hope that makes somewhat sense. You'll get a much better picture of that. If you
an actual picture.
Yeah, looking at an actual picture, if you see that, you'll get an idea. But I just want to bring that up anyway. So there's a little space between the cornea and the iris where basically just think about it, that fluid cannot flow out. If the fluid cannot flow out, it backs up all the way into the retina. The retinas, and then it causes destruction of the retinal layers, the epithelial there, and then can cause damage to the optic nerve, and therefore it just can destroy your eyesight over time.
Yeah. Now, when you say emergency situation, more this closed angle situation, do we have a conventional treatment for that?
Yeah, we do.
Can you go get it drained or?
Yeah, no, and that's exactly right. I mean, you're thinking about it right. Yes, you want to get the fluid out of that area, or at least release the pressure. Then that's typically how you will treat it, right? From a conventional standpoint, you can either do that through drugs or through surgery. Okay. Typically, it's kind of a therapeutic order. It's try the drugs first. Drugs don't work. Do the surgery. And there's specific types of surgery. But no, you hit it right on the head there by saying, yeah, okay. So how do we treat it? Well, we got to get rid of the fluid. So how do we do that? And there's conventional surgical ways to do that. Okay. Yeah. So usually the main issue, but it's not always the issue, but I would say 90% of the cases, right? It's elevated intraocular pressure. So when you go to your optometrist, what they're going to do is they're going to get a measurement of that. They use something called a tonometer that will tell you what your IOP or intraocular pressure is. Mm-hmm. And that should fall between 10 and 20 millimeters of mercury. And if it's any higher than that, yeah, you're at risk for glaucoma. And so basically, just to go back, it's just glaucoma is caused by poor drainage of that aqueous humor from the front of the eye, right? And that basically causes oxidative stress, mitochondrial dysfunction all the way back into the retina and to the optic nerve, right? So we've talked a lot about oxidative stress, talked a lot about mitochondrial dysfunction. It gives you an idea of what nutrients we may want to use to help keep our tissues healthy. I just really want to reiterate that most people are not aware that glaucoma is happening. So that's why it's good to get a baseline eye exam. So I one thing about this podcast that I hope all people will do is ask and get a baseline eye exam. Whether you think you have good eyesight or not, you should do it. So anyway, I have mine scheduled. So
Do you know how they look at the intraocular pressure? Is that just through that machine you were talking about, or is this because I
yeah,
think of
I don't know all the details. They call it a tonometer that
uh-huh.
will get you that intraocular pressure. But even with when you go for an eye exam, he'll do a number of tests like baseline visual exams and all that
Yeah.
stuff. But
That's what I was about to say. When you go to the optometrist, you got like your 9 layers of hell there where they like spritz in your eye and
right,
all
yeah.
different things.
See, you probably know more about it than I do, right? Have you had regular eye exams?
For the last 2 or 3 years, yes, because of the
Okay.
glasses
Yeah.
situation now popping up.
Yeah, right. So most people like I don't wear glasses, although I may need them. I'm gonna go find out soon. But yeah, most people wear glasses already had their baseline eye exam, and
Hmm.
they usually get their eyes checked, which is good. That's one advantage of having glasses. You can pick up the stuff, the serious stuff before it actually happens.
Yeah.
So
Yeah. And it's just worked into, it's like your annual physical, just focusing on your eyes.
yes, yeah.
You want that to be, you want that to last.
Right. No doubt. Exactly. And the other thing I also want to say is, your eyes are basically brain tissue, exterior brain tissue. That's your eyes are nervous tissue, part of your brain. And it is interesting that there does seem to, when we talk about cellular debris, kind of clogging up the plumbing in the eye and then you therefore get this intraocular pressure. It is kind of similar to other neurodegenerative diseases like Parkinson's and Alzheimer's. It's basically a buildup of cellular trash, possibly that causes these types of, the primary types of glaucoma. So that's me too. That as brain tissue or as your body builds up cellular trash, you just get a degradation of how things function.
Yeah.
So what are I think we should go into like what are the risk factors, and we can talk about them a little bit. But family history seems to play a role. Their genetics certainly can play a role there. There's certain genetic markers that are coming on the scene that are seen to maybe increase your risk of that. It's funny, when I did the 23andMe genetic stuff, they just see how prone you are. Glaucoma is one of the medical conditions they do, and they look at certain SNPs there that may elevate your risk of that.
Mm.
Probably one of the biggest risk factors is advanced age. I mean, that's why you should really try to get your baseline eye exam early on. Ethnicity plays a role too, and it seems like African Americans seem to have the highest risk factor, and then followed by Asian Americans, Hispanics, and then Caucasians. There's medical conditions that can increase your risk or seem to have some correlation with it. Diabetes, man. I mean, we talked about diabetes with the other two eye conditions, macular degeneration and cataracts being a big risk factor. It's a risk factor here. Hypertension, and thyroid problems also. So having thyroid issues also may increase your risk of glaucoma. Other eye conditions, eye trauma can also increase your risk there. Prolonged use of steroids, and of course, being sedentary, lack of physical activity. So those are the main ones. Just to distinguish between primary open angle glaucoma, that's, it's insidious. You tend to notice as it really progresses a loss of peripheral vision. And then you have acute angle closure glaucoma. The symptoms here include extreme eye pain, headaches. I mean, this is the one that you feel, and it can come on sudden: blurred vision, red eyes, halos around lights, nausea, vomiting. This is an emergency medical treatment to prevent vision loss. If it's not treated right away, it can really, you're asking for problems.
Yeah. Yeah. And I think just kind of the list of risk factors really highlights the importance of getting that annual checkup and kind of having a baseline. Because really there's, you went through them, but family history, advanced age, ethnicity, other medical condition, really, yeah. I mean, those first three that I mentioned, there's nothing you can really do about it. Other than
Right.
that, you know your medical history, You know, if you have other eye conditions, and then, you know, if you use steroids, you could hopefully reduce the steroid use and you can hopefully increase your physical activity. But really that IOP measurement is the biggest thing that you're going to be able to monitor and see if this
Right.
is.
And that's what the optometrist or ophthalmologist will do. So, you know, they'll monitor that. By the way, speaking of that, Bryan, what do you, I mean, off the top of your head, you may know this better than I do. I always think of an optometrist as being like the PCP of eye care, and then the ophthalmologist as being like the you know, kind of like if you have more extensive work that needs to be done, that's who you
Yeah.
go to.
Yeah. I don't really know the difference between an ophthalmologist and an
And
optometrist.
okay, I think one is more like your think about your primary care physician and the associated specialist, you know. So
Okay.
that's the
So,
way that's the way I tend to think about it. So for your baseline eye exams, the optometrist is pretty much the one you would go to, and I think from there the optometrist can, you know, defer you to the ophthalmologist, or your regular primary care physician, you know, if something was going on, could refer you to either. But
well, just kind of quick Google search. So an ophthalmologist, the long one, the ophthalmologist is a actual medical doctor, where it seems like an optometrist is a healthcare eye specialist.
right. But yeah, okay. But so all right, well maybe that's a difference. I was thinking both were MDs, but maybe they're not. But yes, so and that's opposed to an optician who helps, you know, create lenses, which is just kind of like a technical person for eyeglass, you know.
Right.
So but anyway, I hope that clears that up for some people. I mean, even though we're still confused confused on it, but I can tell you this. My appointment with my eye person is with the optometrist.
Okay.
That's who I set up my appointment with. So we're talking about the IOP, intraocular pressure, and you know that's kind of the measure that we want to follow with glaucoma. But there are, you know, it's rare, but there is also something called normal tension glaucoma, where that IOP is normal, but people still have the typical symptoms of glaucoma besides, you know, that, and so you can actually have that too. So I just want to bring that up. So just because your IOP is normal does not necessarily mean that you don't have glaucoma. So that's another reason, and your optometrist can help you figure that out. And there's other things. There's congenital glaucoma. This is something it's present at birth. Yeah, there's pseudo exfoliative glaucoma. This kind of brings me back to maybe related to like Alzheimer's. And basically you see like clumps of cellular debris like amyloid protein accumulate in the eye, and they actually end up blocking the outflow of the aqueous humor by blocking that trabecular network, so it can't flow out. And that's there does seem to be a strong genetic component with that. Just to reiterate, so as you get that backflow of fluid, you know, into the retina, the optic nerve, the axons, ganglion cells back there, they end up dying, and you start seeing visual changes in the back of the eye, the optic nerve, and those visual changes are usually known as cupping. And you know, the optometrist uses a number of things to help people determine that what's actually going on and how they can measure the back of the retina. So there's certain techniques like optical coherence tomography. It can measure the thinning of the retina, and it also can be used to see if drugs are working with the eye and things like that. But the one thing that can't be done with most things is you can never look within the cell of the nerve tissue and the cells of the retina to actually see what's going on biochemically, right? You're talking about a lot of stuff going on back there, and you don't really know what's going on inside the cell, but you can make a guess that it's usually mitochondrial dysfunction, free radical, you know, damage and stuff like that. And when you and so we know oxidative stress is the major feature of mitochondrial damage. So helping to quell that stuff gives us an idea of what natural therapeutics can do. Also with nerves are very sensitive to the level of glutamate in and around them. And glutamate is something that we certainly need for the body's, optimal neurotransmission of impulses and things like that. But too much will kill nerve cells. So glutamate basically overstimulates nerve cells and can be a problem and cause nerve cell death. So glutamate may play a factor there. And this glutamate may play a role in people where they're just not responding to the IOP lowering treatments, which are typical, right? So if you're getting an eye exam and your intraocular pressure is not decreasing, this may be one of the mechanisms that are causing an issue, and it may be the glutamate that may be causing a possible issue there. So when I really wanted to bring up mitochondrial health because it's so important for a number of things, but one of the most important nutrients we'll talk about in a little while supporting mitochondrial function is coenzyme Q10, CoQ10, and pyrroloquinoline, PQQ, and these are really wonderful mitochondrial supporting natural compounds. And we'll talk about those in a little bit. We talked about how to, look at IOP. That's, they use that kind of like, I don't know, I call it a blood pressure cuff for the eye, but it's a tonometer. And they, and also when you go for your eye exam, sometimes they'll dilate your pupils. I don't know if you ever had that done, Brian. Have you?
Yeah.
When they dilate your pupil, yeah.
It'll ruin your day.
Yeah, right. It does, because it kind of makes your eye, like afterwards, right? You're really sensitive to light, and from my understanding, and
you don't see very well, all that.
Yeah, you're not seeing very well, and it lasts for like a day or so, right? Or a few hours or something. Yeah. Okay. Well, anyways, the reason why they do that is to really get a good visual field into the back of the eye, right? To really see what's going on there. There's another thing called well, you being a PT, right? PTs are like the masters of using the goniometers, right? I would think, right? Well, there's something called a gonioscopy, that it actually measures the angle between the cornea and the iris there. So it's like a eye goniometer. And then they do, then the other thing that they do, so I always kind of laugh at this because it's called NFL scanning technology. So I'm always thinking of the National Football League as that. But what it actually means is the nerve fiber layer, which is you're looking back, the retinal nerve fiber layer, and it's just it's a measure of the damage that glaucoma has already done. So they'll use that too. So what are the conventional treatments? Well, people probably if you've been listening to our podcast, you probably heard of a lot of these classes of drugs, but they use basically topical medicines for the most part. And these fall into classifications of alpha agonists, beta blockers, right? People have heard of beta blockers, carbonic anhydrase inhibitors, cholinergic medications, prostaglandin analogs. And let me just briefly go through both of them, because at the beginning of the podcast, you talked about, well, what do? You kind of have to get rid of the fluid. Yeah, and that's kind of what these things do. So the alpha agonists, they basically help decrease fluid production, right? And increase drainage. So if you're decreasing fluid production from the ciliary body, and then you're also increasing drainage, letting the fluid go through Slem's canal, making sure that it gets through out there, then you're taking pressure off the eye.
Yeah, that sounds like what we want.
Right. So these drugs are a common one is lopidine, and then alpha-gan. These are alpha agonists. The beta blockers, again, these are the eye drops, so these are not typically the oral ones that you're taking, but they basically decrease production of the aqueous fluid too. The problem with all of these is side effects with these, right? So side effects of beta blockers, lower in blood pressure, decrease heart rate. The side effects of alpha agonists, you kind of get dryness, you know, that's just the way the drug works. You get dryness of mucous membranes. And so hence, you know, decrease in fluid production. It's like a drying effect from these drugs. The carbonic anhydrase inhibitor, again, it decreases the aqueous fluid production. What are they? Oh, the side effect for this one is possible kidney dysfunction, you know, so these things are not without problems, but you know, it's like with all drugs, you weigh the advantages and disadvantages. And if you're doing them in the right way, for most part, most people won't have issues with this. And it certainly will help preserve eyesight. The prostaglandin analogs, you know, common name, Travitan, Lumigan, Zalatan, they basically reduce aqueous fluid drainage. They help with drainage, and therefore they all decrease the intraocular pressure. So let's say you go through that. That's kind of the first round. That's kind of the first stage of conventional treatment if you have glaucoma, especially if it's more advanced, and then the next stage would be surgery. And so these surgeries, without getting into the details here, all we're trying to do is create a way to get rid of the fluid. So you can do surgical, like little, I mean, it's as simple as this, like putting a hole or a canal artificially in the eye to help drain the fluid. That's one of the ways it works. Creating more space with the eye, either through laser surgery or whatever, so that fluid will drain off. And that's as simple as it is. I mean, I know, you know, people think it's really technical, but it's really just, okay, well, we're just going to create little holes here and create more space here by, you know, shaving the lens off there or whatever they're doing, puncturing a hole, maybe plumbing the Schlemm's canal, and getting the fluid to leave and decreasing the pressure. For primary closed angle glaucoma, this emergency surgery, one of these approaches has to be done. You know, the drugs usually are not going to take care of that one, but primary open angle glaucoma, that the drugs usually can help. So, you know, so where's our pet peeve, Brian? I mean, my pet peeve is, okay, so they say these are the first lines of treatment. Really, the first lines of treatment should be lifestyle change, taking care of your eyes from the beginning. If you really want to say the first line of treatment conventionally, without even going into any nutrition stuff, is getting an annual eye exam, you know? And so that's what people need to do, and it will see all kinds of things, catch eye problems long before they become a real issue, even with macular degeneration, cataracts, and so on and so on. So I will come back and give you a report on my eye exam, which I have next week.
Good luck.
So, yeah.
Find out the difference between an ophthalmologist and
an
optometrist.
optician, optician, optometrist, ophthalmologist. I think we have it right, but yeah, I will definitely ask him. I will ask this doc this. So let's go into some of the natural therapeutics. I mentioned, you know, we want to support mitochondrial function, CoQ10, PPQ. Those things are really important. A couple of nutrients that really have some neat research on them are pine bark, or French maritime pine bark, bilberry extract. Bilberry is the European version of the blueberry, so blueberries probably help also, but bilberries are just packed full of proanthocyanidins, and they've shown to support cardiovascular health, you know, capillary health, you know, any type of vascular health. They're really good for, and pine bark really helps. And the studies on these two nutrients, when used in conjunction with some of the conventional medications for improving IOP, you see the most rapid drop in intraocular pressure when you use a combination of the conventional treatment as well as the natural treatment, and specifically with these two compounds, bilberry and French maritime pine bark. So eat your blueberries and your bilberries. They will help. And it's really interesting, like when you combine in a lot of these studies, when you see the studies done with the conventional approach combined with the natural approach, most of the time you see the best outcomes when you use a combination of the approach. But when done separately, even just using the pine bark and bilberry, it also, according to some of these studies, also lowered intraocular pressure without even using the conventional treatment. So that's pretty cool too. So, yeah, as in terms of your therapeutic order, natural treatments are good. You can do those long term. They're not going to hurt you. Lots of good things there as far as having broad acting effects on the body also. So another powerful antioxidant is vitamin C. The thing I like about vitamin C is, and a lot of people don't think about this, they just think about it as an antioxidant, but it really helps with the structural integrity of your body's tissues, especially collagen. So you're talking about vitamin C being good for, maintaining the structure of the eye, bones, joints, tendons, ligaments, and it's great. And it's a great antioxidant. And if you maintain collagen and its integrity, guess what? You're maintaining the integrity of blood vessels and the trabecular meshwork. The theory goes, if you maintain that, then you're going to have good flow of the aqueous humor in and through the eyeball.
Yeah, helps their soft tissues quite a bit.
Right. Vitamin A is another one. A lot of people probably heard vitamin A. If you have a lack of it, significantly deficient in vitamin A, you can get what we call night blindness. Anyway, it's necessary for the formation of what's called rhodopsin, and that's the pigmented compound in the retinal cells. It allows you to see in low light. Hence, if you don't have it, you don't see in low light, so you get the night blindness. If you take a good multivitamin that has real vitamin A in it, the multivitamins we recommend have both real vitamin A as well as beta carotene. It can really help. Vitamin A is found in like green leafies, egg yolks, cod liver oil, any foods that are red, like we talked about this on our tomato podcast, are full of carotenoids, beta carotene, orange, red colored foods like tomatoes. Another one that's good, I've used it as basically a neuroprotector for brain. We know the eyes are an extension of the brain, and lo and behold, when we look at this particular herb, ginkgo biloba, and we did a podcast on ginkgo biloba, we do see that it does seem to have some benefit for IOP, decreasing it. And of course, it's a good antioxidant, helps reduce oxidative stress. Ginkgo biloba has been shown to improve blood volume, velocity of blood flow in the eyes of healthy people. So the theory goes that it may help with, glaucoma. Of course, all of these natural therapeutics need more research, but the nice thing about them are these things are very safe. They're not going to hurt you, and they seem to have some good evidence supporting their use. Now, the two things I use the most for glaucoma and keeping intraocular pressure maintained, and I have a number of patients with glaucoma where this is all we've done. As long as they maintain their eye exams, you can pretty much help people with just giving them magnesium, right? Magnificent magnesium. How much have we talked about that?
Yes.
And then another herb called Coleus forscoli. And these two in combination really seem to reduce IOP, intraocular pressure, when taken together. I've helped, maintain intraocular just these two things alone. Of course, I have my patients on a number of things, and we make sure their lifestyle is in order and all that stuff. But they seem to be really powerful. And when you look at their research, they have some good research supporting, at least preventing the progression of glaucoma by taking these. Mm-hmm. And it's interesting. You don't really have to take a whole lot on those. Other things that you can find in a multivitamin are things like chromium, selenium. There's some research on that as far as helping. Well, we know that chromium and selenium, both of them can help stabilize blood sugar. Blood sugar, we know, is correlated with, at least in our podcast, the number of eye disorders we talked about, including glaucoma. So that's one way, but also it seems to have some benefit for helping keep glaucoma from progressing. And that's not the only mineral. Zinc is another one. All of these can be found in a multivitamin. Hence, how many times we said, yeah, it's probably a good idea to take a multivitamin on on a regular basis, because it can really help, prevent some things. There's another compound that is kind of close to my heart, and it's called PEA, palmitoyl ethylamide. And I think it's found, the reason why I say it's close to my heart and my addiction is because it's pretty high in chocolate and cocoa. But it's really interesting that it actually seems to make the endocannabinoid receptors in your brain and eyes more available to cannabinoids. And there's some interesting research on THC helping with glaucoma. So I just found that interesting.
Yeah.
The one thing that I will say, like anytime you take anything that will lower blood pressure a little bit, right? Mm-hmm. That may actually, in a weird sort of way, exacerbate glaucoma. And why would that be? Well, if your blood pressure is lower, your intraocular pressure is lower, then maybe you're not pushing fluid out the way you need to. Maybe you need a little bit more pressure to help with that. So the research on THC is still ongoing, but it does, in some people, really seem to help their glaucoma. Unfortunately, there's not a THC eye drop that I know of, but if you're smoking marijuana or whatever, of course it's not great for your lungs. And so a route to go would probably be like edibles. And for some people, it really does seem to help.
Yeah.
A very powerful antioxidant, melatonin. It's made in the brain. It seems to reduce oxidative stress throughout the brain and the eye. Other bioflavonoid is rutin. It's found in the citrus family. It has demonstrated some ability to lower IOP also. So those are kind of the main nutrients. Just real quick on lifestyle stuff. It's all the stuff we heard before. We know exercise is a big component for helping maintain eye health. We also know that stress, maintaining your stress or managing your stress appropriately can help. We talked about glasses, like making sure that you have sunglasses that block, most of the UVB and UVA rays. That can also exacerbate glaucoma, as well as cataracts and macular degeneration. Smoking is another issue, not specifically for glaucoma, but we do see it for other eye diseases. And, in general, it's just not to smoke. But those things can really help. It's another interesting thing is the connection between coffee and glaucoma. It may not be so much that coffee helps. I mean, coffee can maybe give you a temporary increase of intraocular pressure, but there is a compound in coffee called chlorogenic acid, and you find this in the green coffee beans or raw coffee beans, and it seems to have neuroprotective action. And this specific compound may also help with glaucoma. Just to sum up, I mean, glaucoma is a very common cause of blindness worldwide, second most common cause, I think, right below cataracts. But it is something that is preventable. If you catch it early, you can stop the progression, and natural interventions can really help. And at the very least, a multivitamin can help. So that's everything I want to go over, Bryan, unless you had other things you want to talk about with that.
No, I look forward to finding out what happened at your evaluation, the difference.
Yeah, I do too, because my eyes, I don't know, they always talk about, you reach 45 or whatever, and then your eyes start doing some weird things. And I think I'm, hitting that right now. So we'll see. I'll give everybody some feedback on that.
Should we look forward to another eye health installment here, or we've done macular degeneration, glaucoma, and cataracts?
We will do other ones, and other ones would, maybe include like uveitis. Well, there are some other ones I wanted to talk about, but uveitis is one of those ones that I think we really should talk about, because that's actually an emergency situation
Okay.
that needs to be taken care of, and also can be a cause of blindness if it is not taken care of. So yeah, we'll talk about some more things about the eye as we go on.
I guess the biggest takeaway is just make sure you're getting a regular eye exam, regardless of vision or
Yeah,
concern about
regardless,
your eye
yeah.
health. It's
And
necessary.
no, exactly. So even if you've been told years ago that you have great eyes, you still should get a regular eye exam and just talk to your primary care physician about it, or go schedule one. Most optometrists, they it's all covered. It can be covered by insurance, and you don't need a referral from a primary care physician, although you can get one.
Okay.
So yeah, that's the biggest takeaway. Take care of your eyes.
Yeah. And until next week, hopefully we were helpful to your ears and your eyes. Then we'll talk with you
Yeah.
next week.
All right, take care, everybody.